Hello, my name is Zoe Safir, and this is the presentation on Public Health Emergency Planning by Zoe, Sienna, and Tatum. So our scenario is that there has been civil unrest in East Africa along with prolonged drought. Refugees have fled their homes in fear and clustered in a makeshift camp. There is overcrowding and a strain on the limited available resources. The rat population has been found to be flea infested, and there is a concern that plague may quickly spread through the community. So, first, nursing priorities, client care. The nurse's primary focus is stabilizing health needs in an overcrowded, resource-limited camp. This includes triaging patients to identify those needing urgent care, addressing dehydration and malnutrition, and managing wounds to prevent secondary infections. Education on personal hygiene and safe food and water practices is critical to reduce disease transmission. The nurse also monitors for early signs of plague, ensuring rapid isolation and treatment of suspected cases to protect both the individual and the community. So the next is another nursing priorities on disaster management. In disaster management, the nurse collaborates with public health teams to implement surveillance systems for early outbreak detection and reporting. They support vector control efforts such as reducing contact with flea-infested rats and help coordinate vaccinations or prophylactic antibiotics if indicated. The nurse also contributes to planning and resource allocation, promotes clear communication within the response team, and provides community education to build trust and encourage compliance with preventative measures. These efforts combine epidemiological strategies with direct interventions to contain the threat and protect the wider population. Next, on nursing priorities, is the epidemiological and communicable disease elements. So in this scenario, several epidemiological and communicable disease elements contribute to the risk of a plague outbreak. The agent is Yersinia pestis, transmitted primarily through flea bites from infected rats. The hosts are the refugees in the camp, specifically those whose vulnerability is heightened by malnutrition, dehydration, and compromised immune systems. The environment, marked by overcrowding, poor sanitation, and limited healthcare resources, creates ideal conditions for rapid transmission. The mode of transmission is primarily vector-borne via flea bites, but person-to-person spread may occur if pneumonic plague develops. Effective control requires surveillance and monitoring through early case detection, contact tracing, and reporting. Preventative strategies include vector control to reduce rat and flea populations, isolation of suspected cases, and possible use of prophylactic antibiotics or vaccines to contain the spread. Next, we have the epidemiological profile. So the plague can be caused by the bacteria Yersinia pestis, and effective disease response includes disease surveillance, rodent and flea control, medical treatment access, education, and coordination between local, national, and global agencies. So for the disease, signs and symptoms include swollen lymph nodes, fever, chills, or weakness. The treatment can include antibiotics, quarantining, surveillance, and vector control. If there is limited access to medical treatment or immunizations, then the sickness may not be caught and disease could be more deadly. So this shows the importance of good communication and education on how to identify signs and symptoms quickly to prevent disaster and to prevent the disease from transmitting. Identification of resources. So local disease surveillance and case reporting includes identification of early signs of an outbreak, track how many are infected, and how the disease is spreading. Furthermore, basic medical treatment by providing immediate care to those who are the most critically ill, prevent the spread of disease. For risk communication, providing information about how the disease spreads and the symptoms to look out for. This can help prevent misinformation, and educational sessions in the camp on how the plague is transmitted will help reduce exposure and where to go when you are sick. On the national level, coordination of national emergency response, the government organizes and leads the response to ensure a unified action. And then disaster management authorities and central operation centers coordinate with aid and monitor the outbreak. And then for the distribution of medical supplies, this ensure doctors and nurses have necessary supplies, prevent running out of supplies, and supplies can be sent in trucks and helicopters to camps. Furthermore, establishing isolation and treatment centers by setting up special areas to not spread the disease to those who are not infected, such as different tents, protective gear like masks, gloves, gowns, and following protocols to avoid spreading the infection. On the global level, global disease surveillance and lab testing support will track how diseases are spread across borders and quickly confirm suspected cases. And then for plague-specific treatment and protocols, this ensure fast and effective treatment, prevent complications, treatments, and antibiotics after lab testing. Next, the identification of agencies. So on the local level, there are local health ministries, which helps with surveillance, case reporting, investigation of outbreaks, and coordination with healthcare providers. There's also regional hospitals and clinics that will provide initial patient care, isolation precautions, antibiotics, and medications. There's also faith-based and traditional leadership groups, which helps to build trust, spread awareness, and support those who are isolated. On the national level, there's a National Disaster Response Authorities, so they coordinate emergency response and communication between the government and aid groups. And then there's the National Public Health Institutes, which leads outbreak investigations, epidemiological surveillance, and testing. Next, there's the American Red Cross. So this provides first aid, psychosocial support, emergency shelters, water, and sanitation services. Then on the global level, there's the World Health Organization, which leads support for plague outbreaks, response, laboratory confirmation, and guidelines for management. And then there's UNICEF, which supports water, sanitation, and hygiene services, as well as protection of children and mothers. And then there's also the Centers for Disease Control and Prevention, which provide assistance, lab support, and help in disease surveillance and tracing. And next is the ethical considerations. So first, we have to respect the respect for cultural identity. So aid efforts must ethically prioritize the recognition and preservation of the affected population's cultural and spiritual identity by acknowledging their critical role in resilience and psychological recovery. And then we must also include spiritual and traditional leaders. So local and religious and cultural leaders should be actively involved in planning and implementing relief interventions, as they serve as a trusted source of guidance and stability within the community. And then for culturally competent care, humanitarian personnel should be trained in cultural humility and sensitivity to avoid ethnocentric practices to ensure that aid delivery aligns with the community's values and norms. Next, we have the facilitation of spiritual practices. So this will be designated spaces that should be made available within the camp to allow individuals to engage in prayer, religious observance, and other spiritual or cultural rituals that provide comfort and continuity. Next, we have the respect for cultural traditions. Relief operations should accommodate cultural expectations related to food, clothing, modesty, and gender roles, especially within healthcare and nutritional services. For the integration of traditional healing, psychosocial supports initiatives should incorporate or collaborate with traditional healing methods to enhance cultural relevance and community acceptance. We then have dignity in death and mourning. Ethical considerations must include the respectful handling of death, including culturally appropriate burial practices and spaces for communal grieving. Community engagement and empowerment. Involving community members in decision-making processes fosters culturally appropriate responses and enhances the effectiveness of sustainability of humanitarian efforts. We then have the nurse's role in disaster planning and relief. So for emergency preparedness and planning, nurses contribute to disaster response planning by helping design emergency protocols, identifying at-risk populations, and participating in drills to test healthcare system readiness. Next is risk assessment and mitigation. The nurses assess community health vulnerabilities, contribute to hazard identification, and assist in developing strategies to minimize disaster impact. And then next is triage and emergency care. During disaster relief efforts, nurses perform triage, provide acute care, manage chronic conditions, and help control the spread of infectious diseases in often resource-limited settings. Advocacy and ethical decision-making. Nurses advocate for culturally competent care, equitable distribution of resources, and the protection of human rights during crises. And then health education and communication. Nurses educate affected populations on hygiene, disease prevention, first aid, and safe use of resources to reduce secondary health risks. Next, mental health and psychosocial support. Nurses offer psychological first aid and emotional support to survivors, helping individuals and families cope with trauma and loss. Next, we have coordination and leadership. Nurses collaborate with multidisciplinary teams, coordinate care delivery, and often assume leadership roles in field operations and mobile clinics. Post-disaster recovery. In the recovery phase, nurses assist in rebuilding healthcare infrastructure, conducting public health surveillance, and evaluating long-term health needs within the community. Next, we have the nursing process. So first we have the assessment. So this is nurses will collect data on the health status of the populations, not just the individuals. And then they will also analyze social determinants of health, environmental factors, disease prevalence, and access to care. Next is diagnosis. The nurse will identify population-level health problems such as malnutrition, infectious disease outbreaks, mental health crises, and then use the epidemiological and community health data to define priorities. Next is planning. So the nurses here will collaborate with community members, interdisciplinary teams, and public health organizations. They will also develop population-focused, culturally appropriate, and evidence-based interventions. Next, they will set measurable, achievable goals that address disparities and promote health equity. We then have implementation. So this is when nurses will actually deliver the interventions at the community or at system level, such as public education campaigns, immunization drives, and advocacy efforts. And then they also emphasize prevention, chronic disease management, and sustainable health improvements. Lastly, we have evaluation. So nurses will monitor outcomes at both the individual and population levels. They will assess effectiveness based on metrics such as disease incidence, behavior change, and resource access. And then they will use the feedback to revise and improve interventions over time. And then these are our references. Thank you.